All right. Thank you so much for everyone being here today. And welcome to our webinar, Methodology of Reliable Search Patterns in CBCT, the Adair Method. This webinar is designed for those who are new to viewing CBCT scans or those who want to improve their efficiency by developing a reliable search pattern. The emphasis will be on reviewing and understanding osseous anatomy of the head and neck in 3D CBCT scans. My name is Yanina, and I'm a Senior Customer Success Representative for our in vivo software and platforms here at Osteoid. A little bit about us here at Osteoid. We are a pioneer 3D imaging software company specializing in vivo software, dental services, and cloud platforms. Originally created in 2004 under the company name Anatomage, now Osteoid. Our in vivo products and services have continued to be the standard in the 3D digital dentistry community. Today, I am joined by an oral maxillofacial radiologist and clinical advocate, Dr. Terry Adair. If you are unfamiliar, Dr. Adair received his dental degree from UCSF in 1987. He practiced general dentistry in Sacramento for over 25 years before returning to academia at the University of Florida in Gainesville. Following his residency in oral maxillofacial radiology, he started working full-time for Beam Readers. Dr. Adair lives in Lake Tahoe, Nevada, where he enjoys the multi-sport lifestyle, including triathlon, snowboarding, boating, mountain biking, paddleboarding, and kayaking. As your co-host today, we're excited to dive into our agenda. A step-by-step pattern to review CBCT scans, advice for understanding the bone structure of the head and neck in 3D, tips to improve precision and lower mistake diagnosis. Before getting started, there are a few housekeeping notes to mention. We will have everyone muted during today's session. Feel free to jot down any questions you may have in the Q&A box. We will save some time at the end to answer any questions you have, and any that we miss, feel free to send them to info@osteoinc.com. Now, without further delay, I will minimize my screen and pass things on to Dr. Adair.
I want to thank you all for joining me, and I want to appreciate or thank Osteoid for hosting this webinar. As Janina pointed out, we're going to be reviewing the Doctor Adair Method. Everyone is interested in the Doctor Adair Method, and you're going to find out it's just my search pattern for reviewing a CBCT. So we're going to go over why I developed the Doctor Adair Method. This is a structured search pattern for CBCT and other imaging. Although in dental radiology, we pretty much just see CBCT. Occasionally we see MRI, but it's not a very big part of, at least my practice. But it is an efficient search pattern that relies on anatomic landmarks. And although this isn't designed to be an anatomy class, it's inescapable that you need to know anatomic landmarks in order to navigate any CBCT, because we're looking at it in 3D. And that's the complexity compared to traditional intraoral or panoramic images. So the importance of having a search pattern, whether you use the Dr. Adair method or any other one, is fine. But you want to develop a habitual search routine that you go through a scan the same way every time. And you either say to yourself or think aloud these landmarks that you're expecting to see, so you can identify any anatomic variants or pathosis. That's ultimately what we're looking for. We don't want anything bad going on, and if there is, we want to see it. And so my method, although it does involve some redundancy in the pattern, and I recognize it, and maybe to some degree that's inescapable, it mitigates missing things. That's what we don't want to do. We don't want to miss important pathosis that's there. Or if there is a anatomic variant and it's not mentioned in your report, then your doctor who you're writing a report for may see this and reply back, well, what is this? You missed something. And it just may be an anatomic variation. Plus, it avoids the Mr. Magoo aimlessly wandering through a scan. It locks you in on a repeatable pattern that hopefully you habituate yourself to repeat all the time. I hope everyone knows who Mr. Magoo is. It may be dating myself a little bit with that. So the intended audience are those who want to improve their search image efficiency. And my method is designed with efficiency, at least for me, and again, to help minimize or mitigate missing things. It's also a bit of a review of head and neck anatomy. Although there are a lot of pipes and wires in the head and neck, what we mostly see are osseous structures. The soft tissue in CBCT is not well contrasted, and so a lot of it looks like gray pudding. And so we have to imagine what's in these canals and foramina, and that's a lot of our landmarks that we're going to be discussing. It's also for those who are wanting an introduction to CBCT or other curious bystanders. As Janina mentioned, I have a background in clinical dentistry. I practiced in Sacramento for 26 years after I went to UC San Francisco. So I went to University of Florida as a non-traditional resident. Most people don't enter their residency at 55 years old. But if those of you who are thinking, is there something else other than dentistry? Yeah, maybe in radiology. I am a full-time practicing radiologist for Beam Readers. And as she mentioned, I'm a multi-sport enthusiast, and that's how I ended up in Lake Tahoe. It has basically all of the things in life that I enjoy. This is Incline Village. This is where I live, and it's probably one of the most spectacular places in Western United States. And this is one of my paddleboarding excursions. And this is what the water looks like. It's just spectacular. It's one of the clearest lakes on the planet. Makes me want to go outside. Maybe I will after I finish our review, and I'm going to jump right into the Doctor Adair method. When I open a scan, I try to look at the entire volume that I'm been given. And this also gives me an idea of the quality of the scan. And this is a good quality scan. And doctors, if you're acquiring your own images, you should strive for an image quality like this. Most of the scans, machines out there, can deliver a very high quality image. So you should become familiar with the settings to yield this level of detail. So I look at the full volume. I just kind of look at what I'm dealt with, and I've selected what I think is a pretty anatomically correct young adult with a good image quality because I want to demonstrate as much as possible these anatomic features as we go through them. So I look at this, then I create a reformatted panoramic view. And part of the reason is just familiarity. We're all familiar with this, and this gives us a familiar looking image that we've had almost whatever our training is in dentistry when we finish dental school or however we've enhanced our education. So this is a very familiar image that we're comfortable with. So this is a reformatted, and the reason it's reformatted and it's different from a panoramic view image that you might get from a panoramic machine is down here in this middle, the user creates the focal trough. So you select that, in this case, because we've selected the mandible, it's kind of this horseshoe-shaped anatomic structure. So it's a curved structure. And we're able down here to select our focal trough right here. And you don't have the superimposition of the cervical spine and other structures that are outside that focal trough. That's the beauty of these. Sometimes the image is as good or maybe a little bit better than panoramics, but commonly they're not. And that depends on, if the patient's really class 2 or if their mouth is open, et cetera. It may alter the width of the focal trough and you get a lot more superimposition of other structures. Again, these are features that I've already set up this morning. I'm using the in vivo viewing software that has these other tools that allow you to create these sections. This isn't those aren't critical for the actual Doctor Adair method, which we're going to get into, but this is just how I approach any image. If these features are in it, I look at the TMJ. As you can see here, this is a nice, pretty healthy TMJ. And then I go to the airway and do an airway analysis. And so I do those probably first, and before I get into going through the actual orthogonal planes, which we're going to right now. And to familiarize you, if you're brand new to CBCT, almost all of the imaging softwares that are out there have this breakdown of the 3 anatomic planes. And I think they're pretty largely featured like this, although where they're on the panel, it may be a little bit different. This upper left panel demonstrates the axial view. And you can see the crosshairs, and the crosshairs represent the planes that you can scroll through. So in order, for example, to scroll through the axial plane, I will select the crosshairs in the sagittal plane. And as you can see, as I'm moving my crosshairs to the superior aspect of the skull in the right plane, and as I scroll down inferiorly, I'm scrolling through the axial plane. Below that is the coronal plane, and then the upper right is the sagittal plane. I want to go through each of these planes, and even though all the anatomic structures are in each of them, they're presented slightly differently. And I think that it helps to be familiar with what they look like in each of the planes. Although when I'm doing my actual scrolling, I am focusing on one particular part of the anatomy. I don't try to take everything in at one time. And those of you who do and can, that's great. It's just too much for me. So I'd rather move quickly, focusing on one part of the anatomy, even if I have to go back and scroll through it again and focus on another one, because I can do it very quickly. The actual time that it takes me to scroll through a full image is a lot faster than what I'm doing now. Of course, I have to slow this down for presentation purposes. But the Dr. Adair method begins by my grabbing the crosshairs in the sagittal plane and moving it to the most superior aspect of the scan. And I'm going to be scrolling inferiorly. And the beauty of this is the anatomic structures that we're going to review very elegantly and gracefully will roll out in front of us from the superior aspect to the inferior aspect, from the anterior to the posterior. So it's very beautiful and elegant how this happens. And you can really scroll through one pass and you can see all the anatomic structures as we're about to show. I've selected this scan because it is a full volume. So you may not always get a full volume scan, but whatever size scan you use, if you use the same system, you may not see all the same anatomic features, but those that you see will be familiar and you'll be able to recognize them. So this takes a little bit longer if you have a full volume scan. So starting right here, I scroll through, and what you're going to see initially are the frontal sinuses. You can see this up here in the sagittal plane. So we're scrolling through the frontal sinuses, and we're going to scroll through the orbits and through the ethmoid air cells. So you can see I'm scrolling superiorly, inferiorly. And then the first notable anatomic structure, I kind of say this under my breath, and it is not exactly true, but it's somewhat true. But I will say that the superior orbital fissure is open. And that's what's happening right here. So this is a superior orbital fissure. This is an important anatomic landmark because very important nerves and cranial nerves and vessels travel through the superior orbital fissure. So again, this is going to just roll out for us anatomically. And right at about the same time, the optic canals open up right here. So we see the superior orbital fissures here, and this is symmetrical. So we have the left side and the right side, and the same with the optic canals. And obviously the optic canals are where the optic nerves live. The importance of these structures, again, that you can't see the nerves and the arteries, but we're looking to see continuity. If there is disruption of the cortical borders, or if they're enlarged or irregularly shaped, it is a hint that something pathologic may be going on. As we scroll more inferiorly, the optic canals close right there. They've closed, right? The superior orbital fissures are still open. That's the term that I use. You can use whatever term or whatever prompts you as you're scrolling through this. And as soon as the superior orbital fissure closes, we're going to see rotundum open. So this is foramen rotundum. This is a beautiful looking example of foramen rotundum. Also, I want to scroll up here a tiny bit as well, right at this point here. At this point here, we see the pterygomaxillary fissure and the roof of the pterygomaxillary fossa. So this is an important anatomic structure because these cranial nerves that I just touched on a moment ago live in this area between the sphenoid bone and the posterior aspect of the maxilla. In the sagittal view, we're going to look at these again, and it shows you that sort of that classic pterygomaxillary fissure that you see on your panoramic image. This gives rise to the sphenopalatine fossa, and the nerves for the incisive canal travel through here, and on each side they're along the septum, and then they exit through the incisive canal, which we'll see later. So again, we're scrolling through. We see foramen rotundum open here. And as we scroll inferiorly, right inferior to that is Vidian canal. Now, the Vidian canal is often very, very difficult to see. And you can't see this is pretty well demonstrated in here. So this is Vidian canal. And again, these rotundum and Vidian are leaving the sphenoid bone, traveling in that space, the pterygomaxillary fossa, between the sphenoid bone and the posterior aspect of the maxillary bone. At the same time, and I am going up and down a little bit just so I can, in detail, show you these structures that begin to show up. Right about the same time rotundum appears, you also see the carotid canals. The carotid canal, the carotid does not come through foramen lacerum, as you may have been taught in dental anatomy in dental school, as I was. The foramen lacerum is an artifact of a dried skeleton or imaging. It actually is cartilaginous, and I think like an emissary vein or something passes through that, but the carotid artery does not. The carotid artery actually is in a canal, but this is its superior ascent, and it parallels these structures and travels through the cavernous sinus. So I'm going to go more inferiorly, and you're going to see now the horizontal aspect of the carotid canal right here. And so as I scroll more inferiorly, it's going to exit the actual carotid canal where it comes into the base of the skull. So I'm going to scroll back up again. And I'm going back and forth slowly just to demonstrate these structures. So as you're scrolling through, you see rotundum, you see the carotid canal, and at the same time, we're going to begin to see ovale form. This is foramen ovale, one on each side. This is where the third branch of the trigeminal nerve goes. So this is what supplies innervation to the mandible. And so it travels through this right here. Some of the structures that we see are perfectly, beautifully anatomically described like you'd see in a textbook. Some of them aren't always so much. And so just posterior to ovale is a smaller canal, spinosum. And it's not always as evident and can be a little bit smaller. And sometimes it sort of piggybacks right next to ovale. The beauty of this structure here is that we can see the carotid canal here. We can see ovale, and it's separated by the internal auditory canal right in here. And as we scroll more inferiorly, right here, this is where the carotid canal enters the base of the skull. So it's more posterior. So it travels in the base of the skull slightly from the posterior lateral, and then it travels just slightly medially and anteriorly before it turns upward. The carotid canal, particularly in the coronal view, as I'm going to demonstrate in a few minutes, is important because this is where you can see carotid artery calcifications, and it's a key part of looking for incidental findings as you scroll through your volume. So we scroll through, again, we're looking at the carotid canal. The jugular vein is nearby. Sometimes it's very distinguishable, sometimes it's not. It's probably the most anatomic variant structure that we look for in the skull base. And at the same time, we see the superior aspects of the condyles. So we've gone through this part of it. And for efficiency, what I try to do is hang on to these crosshairs. So when I'm doing this, I literally scroll just like this. And I can see all these structures kind of roll out in front of me. I get to the carotid canal and the jugular vein. Sometimes there's an enlarged jugular bulb. It's not evident in this one. I'm done with this part of it. That's how fast it takes. I hold onto these crosshairs and I move them posteriorly. So now in the bottom left panel, the coronal view, we're going to be scrolling from the posterior anterior. And some of those same structures will reappear. Sometimes I look at them, sometimes I don't, because I feel like I've already looked at them here. But when I scroll from the posterior anteriorly, the first thing I begin to look at are the mastoid air cells. It's fairly uncommon to have them opacified. I've only seen it maybe a few times, 4 or 5 times possibly. Um, but it can tip off that there's something going on if these are fluid filled or soft tissue filled. And so this is the mastoid air cells. And at the same time, when I start to see those, I will begin to see the semicircular canal. This is probably among the smallest structures that we look for, and it's not always evident. And this is so tiny. I'm going to probably blow this up again a little bit just to emphasize. I see it better on the right side. So let me show you right here. If you follow where my pointer is, this is the superior semicircular canal. And what we're looking for here is if there's a dehiscence, meaning is the bone stripped away from it. We want to see the superior semicircular canal fully within bone. And so this is it right here. So you know that the semicircular canal is the organ for balance. And it has 3 circular canals at more or less right angles, not exactly, but more or less right angles to each other. And this is the one that we're looking for primarily here. So I will scroll through here and see if this is fully encased in bone. And in this case, it is. You see this little tiny arch there? So this is a pretty fine structure to look at. And then it comes down here. And then you can see it opens up into where the other canals are. So again, this is the semicircular canal right here. And sometimes you have to go slow here and look at one and then the other side as I'm scrolling. And again, I'm just doing this with my crosshairs for efficiency, but I know I have to move slowly here. And I scroll through, I see both sides. Here's the left side, and it's fully within bone, so I'm okay there. At the same time, here we see the semicircular canal. Porus acousticus, that's where the eighth cranial nerve lives. It's the vestibulocochlear nerve. And again, for our canals, we're looking for patency. We're looking to see that the borders are intact, that they're not disrupted or irregular or enlarged. At the same time, we're scrolling through, we're going to see malleus. This is one of the inner ear bones. Cochlea is going to show up in just a moment. And we also see the external auditory canals to see if there's cerumen. Apparently, we have to look for earwax. Which is not insignificant because I've had a couple of cases where the report is patient claims stuffiness or hard of hearing or something, and lo and behold, it's full of earwax. So I guess that can happen. It's pretty obvious when you see it. So this canal would be full of some foreign object. So again, I backed up a little bit, but I'm scrolling through, and we see cochlea here. Cochlea is a snail-shaped organ for hearing, and it's right here. Again, this is not our area of expertise. We're looking to see if there is a asymmetry, if there is some osteolytic process happening or something happening with these structures that are vary from your normal expected anatomy. And we don't necessarily have to know what any of these conditions are. Some of them we should know, and I do have a continuum on anatomy that I discuss all of those in a little bit more detail. That's not the purpose of today's presentation. So I'm scrolling more anteriorly. This right here is the carotid canal, and you're going to see it turn upward right here. It goes upward right here. At the same time, we're going to see spinosum, and we're going to see ovale. So again, we see these in different anatomic planes. Again, this is I do kind of like looking at ovale here because it gives you this nice presentation of the vertical symmetry of the canal to make sure that it's not widened. And you can easily compare one side to the other if there's something going on there. I am at this point, because right about now we're in the sphenoid bone and we can expect the sphenoid sinuses coming into view. Remember, we started posteriorly and we're scrolling anteriorly in sphenoid sinuses. So for me, this scroll through is focused on the sinuses. I do look at the airway a little bit separately. So we're going to see right here is sphenoid sinus coming through. We see here We see rotundum and median canals. Remember, we just left, we're in the sphenoid bone, and we're going to come anteriorly, and these two are going to empty into the space between the sphenoid, and we're just seeing the pterygoid plates right here. We're scrolling through, and we're leaving the sphenoid sinus, and at about the same time, we're entering the posterior wall of the maxillary sinuses. I'm mostly focused on these sinuses right now, looking for soft tissue accumulations or fluid, or calcifications or anything that may appear in the sinuses. We're also looking at the ethmoid air cells. So the sphenoid sinuses, the ethmoid air cells, and the maxillary sinuses is what I'm primarily looking at when I scroll through in this section here. We do see a little bit of soft tissue thickening, maybe a very small mucus retention pseudocyst. And we're scrolling through, and I will go all the way to my anterior border. So far in my scrolling, I've held on to this one crosshair. I scrolled inferiorly, I scrolled anteriorly by holding on to this. I'm going to leave this now and come over to I'm in the coronal view. I've grabbed the crosshairs here, and I'm going to scroll looking in the sagittal view from the right side to the left side. And I normally start around the external auditory meatus, and I want to start there because there's an important structure that's very delicate. I think I have a good one in this case here. Is I'm scrolling from right to left, right here. Oh, let me use my mouse wheel here. This right here is the sphenomastoid canal and foramen right here. It's very tiny. You don't always see it, but this is where the facial nerve lives, and this is where it exits right here. So the facial nerve, your cranial nerve number 7, exits here. It immediately travels through the parotid gland. And this is very important because if there is a parotid gland tumor, it can travel through perineural tumor spread up this canal. So this would be enlarged. I've not seen that, but not any of my patients. I've seen it before, but not any of the ones that I've come across. So I'm going to look at this or sphenomastoid canal and foramen right here. Again, I'm grabbing the crosshairs in the coronal view. I am scrolling from patient's right to left. And about the same time, you're going to see the maxillary sinus appear right there. And so that's my focus right now. I'm getting it for a couple of reasons. I want to see that the borders are intact, and we're going to see that pterygomaxillary fissure form right here. So this is that border between the posterior border of the maxilla and then the anterior border of the sphenoid bone. And this is where those critical cranial nerves and vessels live. And so if there's an enlargement or displacement, some disruption here, then you know sort of what you're dealing with in this area here. So we're scrolling through this. This is sort of the classic structure that you're going to see on your panoramic panoramic view that you may be used to seeing. We're scrolling through the maxillary sinuses and headed toward the patient's midline. And about that same time, sella turcica appears. This is where the pituitary gland lives. There is a way to measure these. I don't want to get in a lot of details there, but largely you just catches your eye if it looks enlarged. So there may be a benign pituitary hypertrophy or adenoma. And so you always want to look at this to see if it's sort of regularly shaped, and then to get an idea. If your question, if it's enlarged, then there are ways to measure it. I'm not going to go into that today. That's for the anatomy continuum. About the same time, you're going to see the nasal septum. It's very thin in this view, and commonly, very, very commonly, patients have a deviation, so you may not see that full nasal septum as you scroll through the midline. You're going to get the sagittal view of the frontal sinuses. I continue to scroll, and now we've passed through the midline. We're going to expect to see the same on the left side. I look at the ethmoid air cells. Scrolling through, we're going to see the left maxillary sinus, the pterygomaxillary fissure on the left side, and then we're going to look for that canal. It's very small. Right here, it is on the left side. So now we've scrolled from left to right in that plane. I'm grabbing onto these crosshairs. I am now going to move it anteriorly. And there's going to be a little bit of redundancy here, but I've focused on those structures. I know which structures I'm looking for, and I can move through them very, very quickly. And so now I'm going to start from the anterior. We're going to get our first glimpse at the nasal valves. These are the external nasal valves. Um, there are actual measurements here. A lot of it for me is just kind of a subjective appearance. Do they look wide? Do they look narrow? If one side's narrow, it's always going to be this deviation of the anterior nasal septum is going to lean to one side or the other. And this is just cartilage structure, so it's not that uncommon at all to see a deviation there. But again, I'm grabbing these crosshairs. I'm moving efficiently from the anterior to the posterior now. I'm mostly taking, and you can see there's kind of a little kink. I would just call this mildly S-shaped to the nasal septum. It's basically everybody has some degree of this. But it can be notable. If it touches, clear to the other side, then there may be an airway issue there. So I don't want to discount the importance of that and just the airway itself. And again, that's for another discussion because we're becoming more and more aware of airway issues in not only grown-ups who have obstructive sleep apnea, but also kids. It can be very important. And these are the anatomic structure. If you get a scan for kids, that really can matter. These sort of these physical things that you can see: the deviated septum, the enlarged adenoids, the enlarged tonsils, all of which, and we're going to get to that in a moment as I scroll through. But we're scrolling anterior, posterior. I'm focusing on the airway. I've looked at these sinuses. I'm really just targeting on the septum, the airway, see if there's any perforation of the septum, and I go all the way back into the naso and oropharynx right here. And then at this point, I'm going to grab the crosshairs here and I'm going to raise it to the height of the nasopharynx, and I'm going to scroll inferiorly. So now I'm focusing on this coronal plane, or pardon me, the axial plane in the upper left. And this structure here, this may not be the best example because the adenoids are a little bit enlarged. We're going to look for these familiar soft tissue landmarks, in this case, the torus tubarius. And superior to that, or anterior in the upright patient, this is the eustachian tubes canals right in here. And then as we scroll more inferiorly, we don't see it very well. This is the fossa of Rosenmuller, or the posterior recess, and the adenoids are in here. So if the adenoids are enlarged, these structures sort of get pushed out of the way, and you may not see very good detail of these structures right here. These are the adenoids right in here. So this is the upper aspect of the nasopharynx. The nasopharynx is from the height to about the level of the hard palate. So the nasopharynx is not a very big anatomic area. Your oropharynx extends from the hard palate to the tip of the epiglottis. So it's a much bigger part of the airway. But I am focused just on the airway at this point. And the reason I want to just focus on the airway is several structures appear as you scroll from the superior down to the inferior, down to the epiglottis. And there's 5 structures that appear there. I hope I can remember them all. Probably the first one you're going to come across is tonsillis. They are on the lateral border of the airway. They are calcifications of this lymphoid tissue in the tonsils, and so they're not all that uncommon. They're easy if you're not familiar with the anatomy and the height of the oropharynx. It's easy to confuse them with carotid artery calcifications, which was one of the 5, so that's 2. So the carotid artery calcifications are typically going to be in, although I've seen a little bit higher and maybe a little bit lower, in maybe the C4, C5 range, right in there. So you want to be able to distinguish those. The tonsillis are typically a small cluster, although there may be singular, but typically a small cluster of radiopacities. And as you scroll inferiorly, we're looking at the air. I'm just looking at the airway here. And then you can see just the beginning of the hyoid bone. Again, not all of the structures appear perfectly all the time. So you need to sort of use your discretion and your familiarity with anatomy to decide what's what. So these are the structures that may fall in this area. We already talked about the tonsillis. This is the hyoid bone. Ossification of the stylohyoid ligament may also appear in here, and sometimes it's not continuous. You may have interruptions of ossification of the stylohyoid ligament, and it may be ossified at one end, which is probably more typical from its origin. It may be more ossified there, but it could be intermittently ossified along its length all the way to where it attaches to the hyoid bone. And so it may appear just as a punctate little radiopacity that you may confuse again with calcification of the carotid arteries because they're going to appear in a similar area now because we're kind of in that C4 area. So you have the tonsillis, you have the hyoid bone, you have the carotid artery calcifications, you have the stylohyoid ossification of the stylohyoid ligament, and then you have ossification of the thyrohyoid ligaments, which fall inferior. The most common one, and it's probably not in this case here, as you scroll to the inferior right here. So we're at the inferior aspect of the hyoid bone. So if I move this over here, we can see the hyoid bone on the sagittal view. Right inferior to that are the tracheal cartilages, and they're spherically shaped, and they can calcify and ossify, and they're right in that area that might trick you if it's to think it might be a calcification of the carotid artery. Normally, they occupy pretty distinct anatomic areas. So with experience, you can decide which of those four that it might be. I generally draw an imaginary triangle. In fact, I might just do it since we're doing this here to about the midline here and right in here. So this area here is where all those structures can and do fall. The five structures that I named, and so you have to sort of look out for those in that area. So now I've scrolled the oropharynx. I go to the inferior aspect of the scan, and now I'm going to be looking at the cervical spine. And primarily, you may see these continuous or you may not. And you have to sort of, in your mind, complete the circle. This is the transverse foramina right here on the right side and left side of the vertebrae, and then the lamina. So I want to just look at these structures here. I want to make sure that these are intact. In fact, just yesterday, I found a fairly enlarged transverse foramina on the left side, and I shared it with my study club, and we had a discussion: how common is that an anatomic variant, or is there a neural or vascular tumor there? I don't know. I identified it. I put in a report and made a note to the doctor that patient should share this finding with his physician. They can decide. I don't really know. But it was notable enough. So you do want to look at these foramina because occasionally I've actually seen a fair amount of these. So now I'm just scrolling superiorly. Again, here's a transverse foramina. I'm looking at the lamina to make sure that everything's intact here. Scrolling superiorly, again, transverse foramina on C3. Now, C2, which we are right now, odontoid, atlas and axis have their own unique anatomy, but they still have this foramina. I'm going more superiorly. Now we can see the tip of C2 right here. Here is the arch of C1. And I go to the very top here, right here. Then I glance in sagittal. I look at the relationship here from odontoid to basion right here to see if there's a space to make sure that this is not impinging or intruding into foramen magnum, which is anatomically important. So we see C1, C2. I'm still holding on to these crosshairs, and I will move posteriorly. And this is very quick and small. These last few parts are super, super easy to go through. I'm scrolling posteriorly, and I want to stop and pause about right here. I want to look at the base of the skull, C1 and C2. I want to look at these spaces right here. If you have decreased space there, commonly you're going to see this, more often in older patients where you have sort of that compression of those vertebral spaces. You're going to see the development of arthritic changes, sclerosis, or maybe osteophyte formation. So these are all things that we want to keep our eye out for. This right here is maybe not the best example, but this right side might be a little bit better. It took me a long time. I kept hearing the eagle view for a long time, and some of you may be familiar with that. I've always wondered, well, what is that? It took me a while to figure this out. this is where hypoglossal passes through. And so this is the eagle sign is kind of like an eagle's beak in profile. And so I scroll through that. Again, I just want to make sure that this foramina is intact. So I begin anteriorly. I'm scrolling posteriorly. I see the hypoglossal. I've seen the relationship of the base of the skull, C1 and C2. And I'm scrolling and just to look at the whatever the posterior aspect of the cervical spine I have. And then one last look, I am going to grab these crosshairs just to the lateral side of the cervical spine. And right here, you can have ossification of this posterior loop of C1. And this is where you'll have a nerve and an artery. And if this loop gets calcified or ossified, actually it's ossification, then you may have impingement on that nerve, particularly if the patient turns his head. And like Eagle syndrome, those are not anatomic findings. Sure, you may want to notate them, and I do, if there's particularly an enlarged ossified stylohyoid ligament, or if there's this posterior ponticle, I will definitely identify that. But those are clinical findings. The patient has to have symptoms with it. So an enlarged ossified stylohyoid ligament in and of itself does not mean Eagle syndrome. The syndrome is patient symptoms that they experience something when they turn their head. In the case of the stylohyoid, you may impinge on the carotid. Here you have a important artery and nerves here. So I look on both sides. So I start on the right side, no posterior ponticle. I scroll through. I pause right here. This is probably the best view of the cervical spine for identifying sclerotic changes, osteophyte formation, etc. You have the anterior and posterior ligaments here. Those can ossify. And again, that's not necessarily pathosis. It's maybe a physiologic change. It's not necessarily arthritic changes, but it may accompany it. And you may see sometimes a strikingly dense sort of band of this sort of ossified structure. And so you have the anterior and posterior ligaments that can ossify. So it gives you a look at that. I scroll through quickly. And then right here, just so you see this partial formation of a ponticle. I wouldn't identify that, but you can get an idea that this can ossify into a full little loop there. So that is my scrolling through of those planes. We're not finished yet. And then, as you can see, I've kept it in these orthogonal views so I can quickly scroll through these. But now, as I come to the nearest and dearest part of what we do, is look at teeth. I save that for last. And because this is important, I generally want to enlarge this. So I'll sort of magnify this. And at this point, I am going to rely on hand scrolling superiorly, inferiorly, because I'm beginning to look at the dental structures. And we never want to miss things for sure. Pardon me. But what we don't want to miss is something wrong, pathosis with the teeth. Pardon me, everybody. It's bound to happen. So I'm going to scroll through, and I want to start at the superior point of the apices. So this is a point where you might begin to see periapical pathosis. I'm scrolling through inferiorly, and about right here, I want to pause because this is commonly where you'll see invasive cervical resorption. It's not all that uncommon. And this is important because you almost will never see these early on, at least for sure, in your intraoral images. And so this is a excellent opportunity to look for a fairly common condition. So I want to sort of pause, recount my teeth, relook at it, make sure there's no supernumerary teeth hiding in there. I'm scrolling inferiorly. I'm going to be coming into the occlusal aspects of the mandibular teeth. And right about this point, again, I want to pause and kind of go through and look at all of this. I selected a case that's more or less pathosis free just for demonstration purposes. In my other continuums, I have incidental findings and the things that kind of scare us as dentists and radiologists. And I scroll. Now I'm done here. I click out of here. Now, where I'm here in the posterior, I'm hand scrolling, so it'll give me a chance to kind of relook at some of these structures again that I may have missed. I'm scrolling through this quickly because I want to get to the dental structures. There's a couple of structures that are still important for us to find that we're going to come across momentarily. Right here. I look at the lingula right here. So this is where the V3 enters. Remember, it exited the skull through ovale. It travels to the soft tissue. It drops in here. This is important anatomic because this is where we deposit our anesthetic to block these. And I'm scrolling anterior, and we can see the mandibular canal is well corticated. There's no enlargement. This is important here because we're seeing the pterygoid plates. We're going to see come in here, right here, the palatine canals. So you want to make sure, again, that the greater palatine and lesser palatine canals are intact. And we're going to finally start to see some teeth. And again, I'm scrolling through here looking for periapical pathosis, looking for periodontal osseous defects. And just scroll all the way through. Momentarily, we're going to see the mental foramen. Again, we're looking for continuity, make sure there's no disruption, make sure they're intact, that they're symmetrical looking. Primarily, I'm focused on the dentition. If you have a lot of restorations in there, it obscures and generates so much artifact. That's why I picked this to minimize that. And again, you want to look at all of these structures all the way through. Then I go to the sagittal view. I start on one side or the other. Typically, when I've gone through my scan, my cursor was left on this left side. I go until all the teeth disappear. If they're third molars, I want to see them as well. I'm starting from the patient's left. And again, I'm primarily not, we've looked at everything else. We can focus just on the teeth now. And this is our area of expertise. We don't want to miss something here. So I'm scrolling through the sagittal. I believe that the sagittal view, particularly if there's no restorations, will give you the best look at the teeth for pathosis. Caries detection is not fantastic on this, particularly if there's restorations. There's just too much artifact to look around. But the sagittal view gives me the best look at all of the periapical areas. As you can see, you're going to see each of these multi-rooted teeth. You're going to see them all in their full glory. I'm scrolling from left to right. We're not done. There's still more anatomic structures to look at. This is probably the last one that I look at. I like this in the sagittal view because it gives you the best glimpse of the incisive canal that we're coming upon right now. And if you know this anatomy, you sort of know what to expect and that it's coming, and you're reminding yourself that you're anticipating to see this coming into view. We showed previously where this comes through in the sphenopalatine fissure. It travels along the septum and then it drops down here. So if there's a cyst in here, and it's the most common non-odontogenic cyst in the mouth is the incisive canal cyst, you would see it right here. This right here, these are just nutrient canals. You'll see a number of them on the mandible. Again, we're scrolling through, going through all of the teeth. You commonly can see the invasive cervical resorption in this view, scrolling through it. You can see other pathosis. You can really see periapical pathosis. That's the beauty of this CBCT, is that really stands out well. You look at the height of the horizontal bone, and here's the stylohyoid, ossification of the stylohyoid ligament right here. This is not part of what I want to show. This is where the carotid canal comes in. And we're going to get to the very end. I wanted to save about 10 minutes at the end to answer any questions that you might have. And we just went through the Doctor Adair method. And that method allows us to view all of the anatomic structures in a methodical, efficient way. It took us about maybe 45 minutes to do that. If you're just looking at a healthy individual, it takes maybe 10 minutes to do that whole thing. If you're writing a report, it takes longer, but just to view that, if it's healthy and there are no disruptions, you have to write this down or write that down, you can go through that in about 10 minutes. All right, I'm going to open up to any questions that you might have.
Perfect. Thank you so much, Dr. Adair. That was a beautiful presentation. It looks like we do have a couple questions here for you. The first question is, when evaluating the airway, what parameters are you looking for to determine if something is abnormal?
You'll have to stay tuned for my continuum on the airway. Um, anyway, that's a great question because it is one of the hottest topics in dentistry right now. Everyone knows about the airway. It's the one there's probably maybe among the most confusion and maybe the least agreement on. How useful is this measurement? What does it really mean to us? And so if you're using a software like the Invivo, this will calculate the airway, not only the narrowest aspect, which is probably what the key to answer your question that we're looking for. What's the narrowest area? What's the cross section of that narrowest airway? But it also looks at the volume. Some people make something of that. I don't really know. So you can have these sort of long, skinny airways or short, fat airways. You use those as information that you deal with. But this is probably what we're looking at right here. This line here identifies where the narrowest part of the airway is. And in this patient here, it's 144 millimeters squared. I would call that normal. Now, as you get closer down to 100, no, you're not. You're getting, and we can discuss that at another time of the significance of that clinically. What does that mean? But more importantly, I look for the anatomic structures that could be impeding airflow, especially in kids, enlarged adenoids, enlarged tonsils. Sometimes they literally almost are closing that airway. I look for that nasal passage, those nasal valves, are those narrow? So I look at those equally to this number right here. And you can see the profile of the airway right here. That's what this line is right here. So it shows you the AP and the right and left distances. So this is right here, it gives you an idea of how narrow that airway is. So this is the narrowest point right here at 5.93 millimeters. And we have an airway of 144 millimeters squared. And I hope that answered your question. Thank you.
Perfect. Thank you so much. We'll do a couple other questions here, Dr. Adair. So it looks like our next question says, for airway, patient sleeps lying down. How does standing capture come into play?
It doesn't. And that's the reality. And that's one of the areas of, I guess, contention within airway analysis. This is not diagnostic. It just gives us some more information, and that's a very, very good point. Um, the other key feature, not just that you're supine or upright, which is an important distinction, believe me, and also just how you're positioned in the scanner. If you're positioned sort of with this lordotic curvature of your cervical spine, right, and you're coming forward, you're actually going to open that airway up. If you're back, you're going to close that airway. We don't really know. I mean, we can look. This is pretty upright if you look at the cervical spine. So I do like this. I think about that and we'll make a note when that happens. The other factor is the flaccidity of the soft tissue, your muscles, etc., become flaccid when you're lying back. And so it's more likely that that soft tissue is going to fall posteriorly, particularly at the base of the tongue, and encroach on that airway space. So that's an excellent question, and we kind of grapple with that. Even with, and these are not easy to do, they've done these functional MRIs where they try to capture the airway, in action while a patient is supine and or sleeping, to try to more closely mimic that airway. And unfortunately, the results are not necessarily great, but they do give some insight that those are important distinctions. If the patient reports snoring, spouse tells you snoring, whatever, you got to believe them. There's no one's going to come in and falsely say I snore. So that soft tissue collapsing in is where you get the vibration of the soft tissue. So I hope that answered that question.
Awesome, awesome. Thank you. The next question here is, what percentage of the time do you find VRFs?
What is that? The VR?
Yeah, I can repeat it. So, what percentage of the time do you find VRFs?
Oh, forgive me. I'm not familiar with that acronym. That's
Okay.
embarrassing. If you could have the questioner ask what clarify
Yeah, if they
that
can
acronym.
clarify it, we can come back
Yeah,
to
please,
it.
thank
No
you. I
worries.
apologize for that. I'm sorry.
Oh, that's okay. Next question here. If mastoid air cell opacification is noted, what is an appropriate way to document without raising major concern to the patient and provider? What clinical scenarios could it indicate? I can
Well,
repeat it
mastoid,
if you like. Okay.
yeah, I get it. Yeah, so he's asking about the opacification of the mastoid air cells. The good news is it's pretty uncommon. Well, almost for sure, it involves some sort of infectious process. So that's going to be the key. It may or may not be clinically symptomatic, so the patient may not even know. They may be completely unaware of it. And a lot of these things they are unaware of, even opacification of the maxillary sinuses, which is very common. So its clinical significance is that it could be an indication of a localized infection, or it could be an upper respiratory infection. I just think we have an obligation, and I think it's easy enough to say that I find this, it's almost always, subclinical presentation. If you're interested, we can come back and re-image it sometime in the future, or a referral to your physician or ENT would be appropriate. It usually just represents a focal infection.
Beautiful. Thank you so much. And just going back to circling back to the last question, Dr. Adair, we had what percentage of the time do you find in vertical root fractures?
Oh, oh, that's a great question. Thank you for that clarification. Okay, I should have probably figured that one out. Not very often. Um, uh, Almost always, this is no one wants to hear this, but the reality is commonly the point at which you can see it radiographically, you can see it clinically. We can, if someone submits a small field of view, maybe just of a quadrant in a high resolution, you can see vertical root fractures. Um, Here's what happens. Commonly, teeth that are susceptible to vertical root fractures are either restored and or have endodontic therapy already. And that gutta percha is highly attenuating and it really creates a lot of artifact in the area. So it makes it much more complicated to diagnose vertical root fractures. I don't see a lot of them. I do see some of them that I just diagnosed that there was no note that there was a suspicion of a vertical root fracture. So you can see them, but as it's not as often as we'd like to, particularly if there is a suspicion from the dentist. Rule out vertical root fracture. The thing that I look for most often is bone loss. So that's going to be a more indirect suspicion of a vertical root fracture. Obviously, clinicians, you already know that. But sometimes those vertical root fractures, that bone loss associated with vertical root fractures, is evident on the CBCT by the time a patient has clinical symptoms of that. So I hope that answers the question. Thank you.
Perfect. Thank you so much. Really appreciate that. I think we're gonna wrap it up with one last question. So it looks like it says here, you mentioned making a note of stylo, like, sorry, I might mispronounce this word.
That's
Um,
fine. It's hard
stylo,
for me too.
yeah. Um, stylocoid ligament ossification, meaning
Good.
you would add it to your report even if there are no clinical symptoms.
Thank you very much. Yes, I do. So the question, Yanina, is the stylohyoid ligament, and
Hmm.
the correct terminology here is ossification. It doesn't calcify; it ossifies. That's bone. So when you have that, you actually have bone growing in there, and if you see them large enough, you can get these pseudo articulations. I always do. That's for me. If you, doctor, are writing the report yourself, pardon me 1 second. My 1 hour timer just went off. Particularly, doctor, if you're writing your report yourself, and I'm gonna kind of add on to this in a moment. Um,
Hmm.
you write down whatever you want. Probably in that setting, it's not important for you to put in the patient's record, particularly if it's not that notable, right? They have to be pretty big to create Eagle syndrome. I do for my doctors because I want them to know that I saw it. I won't capture a picture and put it in the report, but I will comment on all of those pineal gland calcification, which are calcifications, choroid plexus calcifications, I always put those on there. The stylohyoid ligament tonsillis, I always put that on there because I don't want the doctor to go through it and read my report and say, he missed this and not know what it is. Because you may not be able to distinguish between those 5 things that I talked about in the oral pharyngeal area. It could be any one of those. I want you to know that I did see it. And I normally put something that's an incidental finding and it's inconsequential, but I want you to know that I saw it and there's no clinical consequence to it, unless, of course, it is carotid artery calcifications, which I will always report. I do.
Awesome.
May I add to that real quickly because I think we're just
Yeah,
at, and I apologize, just run over for a minute, folks.
well, of course.
One of the most common questions that I get asked is, does a radiologist have to read my scan and write a report? I get that very often. And the answer is no, but someone has to. And that's important. If you are reading these yourself, please, doctor, make a note in the patient's record that you went through it. If there's notation, if you acquire a CT, CBCT, or any image, it doesn't, this is all images, panoramic and intraoral, and there's no entry in the record, it's assumed to have been non-witnessed. That means you didn't look at it. Nobody looked at it. So make a notation. What you write in the chart doesn't have to be what I write in my report. It's going to be very, very different. You should include, because obviously if you have a full volume, there's a lot to comment on. You can't just say, well, maybe you can. I'm not going to say that. I wouldn't be comfortable writing viewed CBCT Devia NL. I wouldn't be comfortable doing that. I think you should identify those basic systems, TMJ, airway, et cetera, as we sort of went over, and make a comment on each of those, indicating that you did review it. So no, a radiologist does not have to, but someone does. A dentist has to look at that and write some sort of report in the patient's record that it was looked at and there was either no pathosis or identified. So in that case, those small incidental findings, unless it's carotid artery calcifications, probably don't need a notation.
Beautiful. Thank you so much, Dr. Adair. Really
No,
appreciate
you're
you for
welcome. Thank
joining
you.
us today. Thank you for everybody else that joined us today as well. We look forward to seeing you all again in our next webinar in the new year. Look out for a follow-up email from us with a link to this webinar recording and answers to any questions we may have missed. All webinar attendees are eligible for 20% off of any software offering. This offer ends on December 31st, 2024. Our sales teams will contact you to review all options for this year of end discount. Have a wonderful day, everyone.
All right. Thank you, everyone. Bye-bye.